And so that's the populations that we're targeting. We look at the step back and say there's huge disparities in health outcomes. How are we going to address these disparities? We go where people are, and it's where they live, work, play, and pray. And so that's it. But we don't only focus on one group of patients. We focus on everybody, who's in the region.
Thank you so much for joining us today, Dr. Levy. I'm so fascinated by your Wayne Mobile Health Unit. I'm so grateful that you are spending some time with us today to tell us about it. Now, to get us started, I was hoping you could talk about the population that this program actually covers. I know you're up in Detroit at Wayne State University, up in Detroit, Michigan. And I was hoping you could give us an idea of like the high-risk group that you actually specifically target with this program, just to give us some context.
Yeah, absolutely. And thanks, Chris, for having me on. It's a pleasure to be speaking with you again. Maybe just to step back, Detroit is a region that has one of the highest concentrations of Black population in the city, right? The city of Detroit is almost 84%, depending on, when you look at the numbers Black. And that's one of the highest densities and concentrations in the nation. And with that comes a lot of socioeconomic challenges in the city itself, which have been well publicized over the years, right? Detroit was a Rust Belt city where, manufacturing had been dying off and things were pretty rough for a while, although the city's doing great stuff, great comeback. Last night there was a big highlight of the city with the reopening of the Michigan Central train station that Ford Motor Company has now made its center of innovation, which is terrific. But the problem is that for all those many years, and still now, right, just because 1, 2, 5 buildings go up doesn't mean the entire population, achieves instant resolution of their socioeconomic challenges. But all that stated, we have a community that is really plagued by early onset diseases, especially heart disease and cardiovascular disease. And because it's such a large, predominantly Black population, there's rampant hypertension, which is poorly controlled, right? We know that the Black population tends to have higher rates of hypertension, worse rates of control, and a greater likelihood of developing adverse consequences, things like heart disease, strokes, kidney disease. And so when we started thinking about where is our biggest yield, what is our biggest bang for the buck, if you will, it was all about targeting outreach into communities for screening of risk factors that lead to those things like high blood pressure, diabetes, high cholesterol, smoking, obesity, and then finding ways to link people from the initial screening to services, that they can follow up with, and incorporating in that not just the medical or the biological aspects, but the social aspects, as we started talking about, right? Socioeconomic factors are a big challenge. And so our initial effort when we developed a mobile unit program, I know we're going to talk a little more about this, but it grew out of the pandemic. Prior to the pandemic, as an ER doc, I've been doing a lot of work in emergency departments, trying to say everybody who comes into an ER gets a blood pressure, gets some screening lab work. A lot of people, can we take that not just for the acute problem we're trying to address today, but to say, what does that help us understand their long-term risk for having some of these conditions that we just mentioned? The pandemic hit, we wanted to get out into communities to do COVID-related work, and then quickly realized we had receptivity in the population to place-based care delivery, and started to transition from pandemic response to portable population health, and focused our portable population health on the risk factors and conditions that lead to the greatest morbidity and mortality in the population. Now, in that mix, there's community members that either don't have insurance or they have underinsurance, with Medicaid and other things like that. And a lot of our effort is focused on that. But we also recognize that when you're talking about disparities, it's not just a socioeconomic issue. We're looking at Black, white, ethnic, groups, Hispanic versus non-Hispanic. And when we try to move the needle, if you will, or change outcomes in an entire region, we have to also focus on the working class, right? And individuals who have jobs, but they also don't maybe have access to all the care services that would keep them healthy. So we really started to say, in addition to going into neighborhoods and bringing, care into communities, we can also work with local businesses, especially businesses that have a concentration of employees that live in the city. And so that's the populations that we're targeting. We look at the step back and say there's huge disparities in health outcomes. How are we going to address these disparities? We go where people are, and it's where they live, work, play, and pray. And so that's it. But we don't only focus on one group of patients. We focus on everybody, who's in the region.
Yeah, and I love that moniker you've given it of portable population health, and I know we'll unpack that in a minute. So, but that's actually a great segue, Dr. Levy. You mentioned a little bit there about how you've worked in the ER for quite a few years, and I'm not sure how much you still have a foot in that world, but I know at least at one point when we talked last, at least a few months ago, you were kind of more leaning towards the portable population health and mobile units, and even expanding actually on that effort. So, can you just give us a little bit of background of expand on what you already kind of mentioned there about working in the ER for a number of years, and how that evolution actually happened to the portable program?
Yeah, absolutely. So I'm a transplanted Detroiter, if you will, or Michigander, more properly stated. I grew up in New York. I went to school in Philadelphia, University of Pennsylvania, and I did my residency training at Bellevue Hospital in New York City. So I've always been an East Coaster and a New York guy, if you will, but was indoctrinated at Bellevue Hospital by my mentor and one of the great people in all of emergency medicine, a guy named Louis Goldfrank, just an incredible individual who really taught me and a whole slew of residents over time that the emergency department isn't just a place where people get care for acute problems. For many people, it's the only place they get care at all. And nationally, in this country for many years, the admission rate from emergency departments has averaged 13 to 15%. So, most people who come to ERs go home. That might not be what everyone thinks about as they hear this, right? Oh, you only go to the ER for severe medical problems. That's not the case, because the ER, as George Bush, when he was president, famously said, is our national healthcare plan, right? It's a place where everyone can go, no questions asked, no insurance needed, and get care for whatever condition it is they're looking for. So you have people who come in because they have car accidents and heart attacks and all that. And you have people who come in just because they need medications refilled and they have no other place to go. So within that context, I moved to Detroit, started working at Detroit Receiving Hospital a little more than 20 years ago, and was astounded to find in this community that's predominantly Black that people here were 15, 20 years younger than what I was seeing in New York City, when they presented with things like advanced heart failure, advanced kidney disease, or strokes. And so it's one thing when you see a 75-year-old coming in with a heart failure exacerbation. It's not good, right? But, 75 is 75. It's another thing when you see someone 55 come in, right? It's very eye-opening and very, from a medical perspective, it's a travesty, right? Because a lot of what leads to that type of presentation are things like high blood pressure, diabetes, high cholesterol, that if you screen for that and you initiate therapy, you can prevent consequences and poor outcomes. So within that backdrop, I'm an ER doc by training, right? So my initial thing was, how do we do the best care for these folks who come in with these cardiovascular conditions? I was always interested in research and always had a bend towards cardiovascular disease. And so came here to Detroit and started a research career focused on what can we do best for the acute intervention. But kind of realized after a bit, we're just throwing Band-Aids on problems, and the fundamental issue, you have to step back. Let's take all these blood pressures we're measuring, because we do a lot of things in the ER, but we do get vital signs in everyone who comes in the door. Let's take these numbers and say, okay, the acute problems we can fix, but when the 85% of people are going home, what are we doing with that piece of information we just gathered? And so I started working with the state of Michigan and funding through the CDC's, Center for Disease Control and Prevention, right? And started to say, can we rethink this engagement? So after we rule out whatever the person was concerned with as an acute problem, or even if they came in just to get medication refills, can we play a role trying to take this data, work with an individual to help them understand the significance, right? You came to the ER for an ankle sprain. We determined it's not, anything that requires, more than an ACE wrap and some Motrin or Tylenol. But your blood pressure is 180 systolic, and that's really the problem. Your ankle is going to heal, but this will kill you, right? And so how do you get people to understand the gravity of that, and then not just say, hey, you got a problem, good luck figuring it out, but get them from A to B, right? Link them to the next level of care. So we started doing some preliminary work where we got grant funding to screen people for consequences, what we call subclinical organ damage, right? So before you have a stroke or before you have a heart attack or develop heart failure, your body's responding to these insults, if you will, things like high blood pressure and diabetes that cause damage. And there's a subclinical period before you become clinical where you could potentially reverse things. We started screening for that to say, could we do more intensive therapy outside of the ER to reverse these problems? And then really the answer always pointed back to just do better blood pressure control. So do we even need to screen for this stuff? Let's just find people with uncontrolled blood pressure and link them to care. So we started setting up these programs and started to really say, we're catching people where they're presenting, which is the ER, and that's great. And then the pandemic hit. And so when the pandemic hit and people stopped coming to the ER for these more routine types of things, in fact, they just didn't get care anywhere, right? They came to the ER when they had worry about COVID or if they still had heart attacks and those types of things. But the more routine stuff kind of went away because people didn't want to be where the sickest people were. And so we started to say, well, maybe the ER isn't the only place we can do this. Maybe we need to be out in the community. And we'd always done community screening events, and everybody knows about these things. You do these mass events once a year and a bunch of people come out and you measure blood pressures and then give them a piece of paper and say, now go figure out what to do. We wanted to do it differently. We wanted to actually get out into the community and really engage people in a more substantive manner, do more effective screening and really build around this concept of place-based care, barrier-free care, and access-enhanced care, however you want to kind of frame it. When the pandemic hit, we started doing COVID testing, COVID vaccination work. But again, that idea of portable population health really aligned with the concept that we had been maybe, dreaming of, if you will, prior to the pandemic, to say, let's get it out of the ER and go into the community. Then the pandemic really accelerated the ability to achieve that vision.
Can you talk a little bit about how you made that allowance to kind of start to pivot towards getting out in the community?
Yeah, absolutely. So first of all, you need the means and the resources to do that, right? And as I said, because we've been doing a lot of research in the ER, I built up a pretty big team over the years. And we would deploy that team to different community events before the pandemic and before we really transitioned to this portable population health vision. When it really started to grow and accelerate is when we started to get funding, which initially supported the mobile outreach for COVID. And that's where I said, right, we needed that kickstart to be able to achieve the dream, if you will. And we set up the first drive-through testing in the region when COVID hit in March 2020, and there was restricted access to COVID tests because all the reagents and the medium and all that type of stuff just weren't available. And so the state of Michigan limited testing options to first responders and healthcare workers, and we set up a drive-through site in Detroit and one in Dearborn. And within 3 weeks, we tested about 3,000 cops and firefighters and nurses and medics and doctors and all of that. And we did that partly to offset the volume that was coming into the ER just for testing. So not sick COVID people, but people who've been exposed and people who had symptoms but weren't, in a critical state or anything along those lines. We wanted to create an offset, a pop-off valve, if you will, right, for the pressure that the ER was under. But as we started to see the pandemic evolve, one of the things that happened in Detroit and New York City early on, and Seattle, and some of these other communities is they became epicenters for the pandemic, and we started to see that there was a disproportionate impact not only on COVID prevalence but on mortality and outcomes in the brown and black communities in and around Detroit, and we started to realize that we needed to get out into the community. We couldn't just wait for people to drive through our testing sites, especially if they were restricted, right, to certain employment status, essential workers and the like. And we started to push back and say, no, we need to get testing for everybody out in the community. So we reached out to the Ford Motor Company, being in Detroit, Motor City, right? Ford had their big celebration yesterday, like we just talked about. And they were very willing to come in with resources to help us get there. They actually loaned us transit vans that we could build upon to take care into the neighborhoods. So we started to say, instead of just having drive-through testing, we can do drive-to. We can come to different areas of the community and set that up. And that was the beginnings of this. And so I would say for anyone listening who's curious, how do you do this? First of all, you got to find a way to get out there and get access to vehicles. And so loaning from Ford was great. But what we realized as we were doing this is that we would probably need to make modifications to the vehicles. And we also, when we first started all this, we were working with volunteers, right? Because everybody wanted to help do something, especially doctors whose clinics were closed and they couldn't do that in areas of, medicine that had, challenges in the pandemic, but people were still, conscientious and wanted to do the right thing. But volunteerism only goes so far, even in the midst of a pandemic. And so while we had volunteers for a couple of weeks, we couldn't rely on that. So we started to say we needed a hired workforce. And the philanthropic community at that time was very eager to do something. What could they do to help this situation out? So we said we need support for personnel and we need support for COVID testing, because that the insurance companies weren't quite ready yet to start paying for this because they didn't really know a lot of, what would be covered. And we also didn't want to create any restrictions or barriers to people getting tested because they had insurance or their insurance didn't cover it or they didn't have insurance or whatever it was, right? So we started to gather philanthropy from various different groups. We had some funding, specific to Southeast Michigan. United Way came in, and others. And in fact, one of our biggest supporters from the very beginning was Sean Penn's foundation, Community Organized Relief Effort, CORE. I got linked up through just some random email from somebody who said, I know somebody who's interested in doing something, and Detroit seems like a place to do it. So I hooked up with their CFO, a guy who was fantastic, and they funded us to start this program up. And we quickly got about $560,000 from these guys to do this. And that enabled us to go from sort of a fledgling volunteer operation to something that was more robust. And then around the same time, in recognition of the disparate outcomes for the brown and black communities here in Michigan, the state of Michigan created a racial disparities task force. And they wanted to A, figure out, where risk was highest, and B, understand what they could do to narrow differences and improve outcomes. At that time, we were doing this philanthropically supported mobile outreach with the loan Ford vans and our hired staff and covered cost of lab tests. And the state said, well, we like what you're doing. We want you to be a pillar of what we're building out. And so we started to get funding from and worked with the state of Michigan and the Racial Disparities Task Force to further design this. Now, all of that was a moment in time that we seized upon, if you will. Where we've gone from there is as we've transitioned from pandemic response, as I said, and I think all of us are way over the pandemic at this point, right? Mentally, physically, operationally, all of that, right? But it's still lingering right now. They're talking about new vaccines and new boosters again in this fall, and I think we're going to continue to to hear about this. But people don't want to come out and get tested anymore in the community. They may or may not come to get vaccines. And there's a lot of outlets for that type of resource. But the idea that we could now move towards portable population health really became, okay, we've built the resource. The state's invested in this. Why let it go? Why not continue to grow and grow and grow? Exactly. So we got, further support and funding from the state, including line item appropriations in the budget, where the legislature and the governor's office are agreeing to continue to support this type of work. But we also got new grant funding. We had money that we were able to work with partners, in several different institutions to get an American Heart Association, Health Equity Research Network grant focused on preventing hypertension. So we work with NYU, who's the lead center, University of Alabama, Birmingham, who's our statistical core, Johns Hopkins, Beth Israel Deaconess, and little old Wayne State, right, in the mix of all of that. But we also got funding from the National Institute of Minority Health and Health Disparities. They had a call out for something they called the Health Equity Action Network. And because our work really was such a unique perspective of, hey, we're going to bring resources into hard-hit communities and at-risk populations, and we're going to screen them right in their neighborhoods. And we had a track record showing that we could do this and that people wanted it. We became one of 11 NIMHD funded centers. And between those two programs, that brought us more than $25 million in additional funding. And
Interesting.
so it just has continued to grow that way. So, I know that's a daunting number to throw out there, and the whole process is probably, very challenging, right, in people's minds when they're listening to this. But it started with a nidus. It started with a will to say we need to get out there in the community, finding some philanthropic support to help us get there, and then really continuing to seek innovative ways to continue to fund the work. But most importantly, all this continues and grows because people want it. And that's what we've seen. And now we're at the point where we've been able to negotiate with payers to get new rates, actually, to have them cover the services we're doing. We work with businesses, like I said, and we're working with their HR departments to see how can we incorporate this as part of their benefits package.
Mm-hmm.
Wayne County, the largest county in all of Michigan, is going to be hiring us to come on site and do this type of work for their employees.
Right.
I think what everyone is starting to realize, and what I hope comes across from this, long-winded answer to your question, is that the time is now to challenge the status quo. And if we think the way care was prior to the pandemic and the way maybe a lot of us would like care to go back to, and that's going to be the answer, we're wrong. It wasn't very good before the pandemic. It got worse during and after the pandemic. And now's the time to say, how can we blow up aspects of the system and really rethink what's needed? If you think of it this way, does a healthy person like you or I need to go to a doctor to get blood work done and accurately measured blood pressure? Absolutely not.
Mm-hmm.
Not that doctors can't do that, but let doctors take care of sick people who have big
Right.
problems.
Open up that access.
Exactly. And let prevention be a neighborhood-based, ready access thing that people can trip over as part of their daily lives. We park in, surface parking lots. We're outside of businesses. When you walk into work, you can go right through our van and get your screenings done. And 15 minutes later, you're in work. And the next iteration that we're looking at is bringing medications to people, having antihypertensives right there in the vehicles. We screen you on a Monday, on a Wednesday, we're there, and here's your bag of prescriptions that, are going to help control what we found through our prevention screen.
Yeah. And what you say really resonates because I did a little bit of research just a few months ago into like pharmacies and how they've, which I think most people don't realize the extent to which pharmacies throughout this whole thing have also evolved. I don't think anybody thinks twice now about getting some sort of a vaccine at a pharmacy, but like before the pandemic, that actually was not a widely held view, right? And I'm also struck by the full circle with insurance you just kind of painted, because insurance was very reluctant, I think, in the beginning to get involved and support things. But now it seems like, okay, now things have settled down a little bit. There's a little more of an understanding. So as daunting as, and I think daunting is the word, as it may be for some, especially physicians or people in your position who aren't currently doing this to dip their toe in the water, as daunting as that is, maybe it's actually a little bit easier in some ways. I don't see if you agree with this, because the insurance piece of it maybe is there now. Would you agree with that to some extent? Or
no, 1,000%, right?
Oh,
because if you don't change the way care is paid for, you're not going to change the way care is delivered.
Right.
So, I mean, it's really fun, somewhat facetiously saying that, to write grants, right? It's a heavy lift, a big process. I've done it my whole career, and I actually, in a really dorky way, enjoy it, But that said, that's not a sustainability model. A sustainability model has to be one where there's ready streams of support and funding coming in. And so if you think about what we can do in a mobile setting, right? And people, again, who are listening to this, if you're really purposeful and intentional about what you're targeting and it's meeting the big needs of the population, then people will come on board, payers, to think differently about what can be done. And also understanding what do the payers want from this? What do they get out of it, right? On some level, the payers, of course, want better care and better outcomes for the populations they cover, their covered lives, and I guess those who they serve. But they also want better case mix adjustment and better phenotyping and understanding of what their covered lives have. Not only is that good to figure out services that are needed, but it also helps to get bigger dollars from the state when they allocate, CMS funding to these managed care plans, Medicaid managed care specifically. So, that's an important thing. And then there are what's called HEDIS measures, which are quality metrics that everybody across the healthcare system is held to, even the plans. And so there are things that they have difficulty getting achieved when you use this, the current system, and we bake those in to what we do as part of our bundled services, so that there's a win-win-win all around. The patients win because they get stuff in their neighborhood and they get it all right there on their terms. The plans win because it's more efficient and more effective, and we win as providers because we have a rate that we can get that sustains the project. And me personally, as a doctor, I can achieve this goal of really reducing the big problem and the thing that's killing most folks in our community.
Yeah, and I like the way you characterize that as it's like healthcare delivery on the patient's terms, and I think that I heard that a few times in my research about your program, and it's so interesting. I was struck by one video I watched where one of your, I believe she's a nurse or some sort of support staff at one of your mobile units was saying that it's better to do the preventative piece in the community as opposed to being in a hospital and have a freight train coming right at me. Yeah. I mean, that's really, and that just really brought it to life for me of what the of how an ounce of prevention is worth a pound of cure, really. She laid it out a little bit of like, get in the community, make those relationships. It's not going to happen overnight. But so can you talk a little bit about that, and also the communications piece of just raising awareness to let people just know it exists?
Yeah. Oh, absolutely. So, part of this, right, and this dovetails a little bit on what we just discussed, is we created a circumstance through the pandemic that people were more self-deterministic about what was happening to them. So whenever I give talks on this, I ask everyone in the room, raise your hand if you got your first COVID test in your doctor's office. Of course, nobody raises their hand. Raise your hand if you got your first vaccine in your doctor's office. Nobody raises their hand. Why? Because we created places where people could self-select to go get their COVID test and self-select to go get their vaccine. And if you didn't get tested, you didn't get tested. It was your choice and your call. And you know what? A lot of people came out and got tested, right? In the early days of the pandemic, we were seeing 4,000 people a month, through our mobile outreach, right? And the majority of that work was COVID-related activity. But we basically said to people, we're going to create an infrastructure that will allow you to go get the test you want when you want it and get the vaccine when you want it. And now that the pandemic's over, we're going to pull all that away from you and make you just go back into the system the way it was before. So the reason I bring all of this up is to say, part of the communication is to say, whoa, we're not doing that here. We're still here for you, right? And so people came to, so we have 8 vehicles. We're revamping our fleet a little bit. 6 of them now are going to be the Ford Transit size vehicles. We have an RV that we just purchased that is focused on a women's health initiative. We're getting another RV type vehicle for our business to business work and work with the county. But the whole point of this is that we are still out there doing this work, and we need to get people to understand, yes, what we did with you, for you, during the pandemic, we're still here doing now, but the focus is a little bit different. So the communication of that is key. The way we've done it to date, the way we did it initially was through the trust lens of our community partners. So we've now done almost 4,300 events since we started this, and each day we're doing 5 to 6 events. We do it 6 to 7 days a week. We just calculated, that we've driven almost 100,000 miles, with
just around Detroit, right?
Just around Detroit,
wow.
Right? And we're going to be, doing some promo around that with Ford because they're obviously, a motor vehicle company, and it makes sense. And we're nearing 95,000 encounters that we've done, and we have a whole litany of things that I can rattle off. But the point is that to keep this going and sustain it, we got to keep people engaged and excited about what we're doing. So we started out. In our first announcements, we would work through churches and develop flyers and hand those things out. And, that's moderately effective, and pastors can speak during their sermons, and, those types of things are good, right? There are neighborhood block groups that we can have, people to proselytize, if that's the right word, about this activity and what we're doing. But we started doing stuff with iHeartMedia and radio spots, which was interesting. And we can get that, feedback on that and how many people you reached. But where it kind of came down to it, and I think you saw some of this, is we had to get, better reach than just radio. People listen to the radio when they're in their car, maybe at work, but it's not what it used to be, right? And television is still king of communication. Even though everyone wants to talk about social media and all those aspects, we do find that commercials are very effective. They're expensive, right? But they're effective. And so we've run multiple commercial campaigns. And because of the work that we're doing, we get very nice discounts and give backs from the stations that we work with, and they try to highlight, the work that we're doing and the commercials we're promoting on programs that are going to be highly watched and things that are going to appeal to the communities that we're targeting. So that's that aspect of it, and we also do social media and other things like that. But a lot of this is just brand recognition. So one of the first things that we did was create a very captivating wrap for our vehicles, right? So that people would know what it is. And I hear people all the time, I saw one of your vans on this street. I'm like, that's great. That's awesome, right? Because sometimes the way this has evolved, when we think of place-based care and mobile care, sometimes we're in a parking lot and people are walking up or they're driving up. And sometimes we're in a rec center in a church or in some of the businesses we work with. We're in the lunch break room, right? And the van is parked outside and it's a giant billboard, but no activity is necessarily occurring in the vehicle because we're bringing care to people. So that extension of mobile is not just mobile and you come get it right from the vehicle. It's that we drive to where you are and then we bring the services on site. And so just keeping that awareness going is critical. When we work with businesses, they often, especially in the manufacturing sector, do overhead announcements for their employees, and they'll talk about, the mobile units here, go get your screenings and that type of stuff. So, there's many, many different channels that we go through. But I think one of the most effective really has been the word of mouth channel, which is, okay, the mobile unit's going to be back here, because we come back over and over and over again to different locations. We weren't there just once during the pandemic and never showed up again. We've been back every month, if not every month, every couple of months. And then we try to get continuity and be in a location for several days in a row too, so that people know that they can always get out there. So the people who come on, again, a Monday and got their screenings may tell, 2-3 friends that we're still there, and they can come on a Tuesday or Wednesday, and get those services. So I think it's a all-inclusive approach that we like to employ, and try to think of what are all the different channels that the people we're trying to reach, might use to get information.
Yeah, and I think that makes sense. Do you actually have some sort of a budget kind of allocated for the marketing, or is it just sort of you go, or?
That's a great question, because a lot of what we do is state funded, right? We have to have very tight budgets and adhere to those budgets, right? And so we have some of the more expensive things come from our bigger allotments of dollars. But yeah, we have a very specific budget around all of this. And some of the funding we get also comes with certain segmented dollars for promotion activities and getting the word out.
Interesting. And I wonder if social media isn't it's almost like you got to kind of consider the audience, right? So, yeah. I mean, everybody's got a cell phone, but not everybody's on social media. So it's interesting that through trial and error, the way that you figured out how that goes. So, I'm just wondering, as we kind of wrap up here, what long range plans are there for the program? And if you could also, just to remind people what specific things you actually are screening for now, and maybe if you have plans to expand that array of screening, maybe talk about that.
That's a great question. I'm delighted to talk about that. So our emphasis, as I said, through the idea that heart disease is a huge disproportionate impact on our population, right? This is one of the emphasis points of all the talks I give, is when you look at the top leading causes of death in this country, the top two are always cancer and heart disease. And heart disease is the most common cause of death in most states in the country. But the state of Michigan is one of 2 states, us and Rhode Island, that's most disproportionately impacted by heart disease death. And so it just stands to reason that that's the focus. But what we're coming to understand, right, is that maternal fetal outcomes are a big emphasis point. We know that they intertwine. High blood pressure in pregnancy is a big cause of worse birth outcomes and maternal morbidity and mortality. And so one of the branch points that we've moved into is women's health, and the RV that we purchased that I just mentioned, that's with funding from Meridian, also known as Centene, a big Medicaid managed care and insurer partner. And we're developing a whole women's health program where our goal is to create a bundle. We talked about the bundle for cardiovascular disease, which includes a very accurate blood pressure measured using an Omron 907 XL, which some of the physicians who are listening may know, but that's That's a way to measure blood pressure in triplicate and take the average, and it's called unattended, meaning you just push the button and you walk out, because there's always that concern for what's called white coat hypertension, right? A physician or a nurse sort of intimidates people and their blood pressure is a little bit higher than it really is. So this is a way to get a very accurate measured blood pressure. And then we do the lab work, and we include some other measures, and always include stress and depression screening and social determinant screenings. But now we're looking at women's health and thinking, we want to make sure we screen women and accurate, and get the care they need before, during, and after pregnancy. And so this is going to be a comprehensive effort to come up with a preconception package of screenings, which goes beyond cardiometabolic. It includes things like, are you still immune to rubella when you got your MMR, vaccine years ago, because that can lead to worse birth outcomes. We can screen for sexually transmitted infections and treat people right there in the vehicle. Syphilis is growing as a big concern in our country, and it's very easily treatable by penicillin, but you got to diagnose it, and then you got to get an injection. We can do all of that from our mobile units. We can talk about giving blood pressure cuffs out to people, especially, women who are looking to get pregnant, and having a way to maintain continuity for their risk factors for worse outcomes. And then when they get pregnant, provide on-site services through our mobile unit, including OBGYN and ultrasound and prenatal vitamins and the like. At the same time, we're growing our business to business. As I said, we have funding from Bank of America to actually offer free screenings, not just to things like Wayne County and those groups, but to small businesses where you may have 1 or 2 or 5 entrepreneurs working in a startup that have no way to pay for insurance. So we can come on site and screen, those individuals, and that's important. But the real big thing that I'm super excited about is there's a program, a funding of research through something called ARPA-H, which is a new division of the NIH. They've been funded for $3 billion, and they have multiple different initiatives that they're looking to go for. And it's not a typical NIH grant, of which I've written and reviewed many. Not gotten funded on all of them, as nobody does, right? But it's a very onerous process. It usually takes a review, a revision, and it could be a year before you ever see $1 when these things go forward. ARPA-H is much more about rapid implementation of innovative concepts, and they have a new program called HEROES. And we're actually proposing in the state of Michigan something called the Michigan Mobile Health Corps, which we've been building out, which is aligning all the mobile health programs that exist, supporting them with startup funding, creating a common way for all the programs to do the same data ingestion and same data intake, and connecting that through the health information exchange, which we have in Michigan, to health systems. So you get a way to reach people in the community with mobile outreach, all the data flow through a central entity up to the health information network. Then anybody who's going to follow up with people have that data at their fingertips. So we don't need to transfer data. There's no faxing of information. It's all just a seamless flow of information in, so that we can tackle at a population level. And I know we were going to touch upon that very briefly, but a population level where risk is, and try to improve outcomes, not one patient, one provider at a time, but 100,000 patients at a time. Yeah. 200,000, right? That's the idea of population health. And and we see this place-based engagement with mobile health outreach as the tip of the spear. And then once things are identified, pull people into the system, but do it in a way that there are no inefficiencies built in.
Yeah, and I imagine that there's a continuity that even goes beyond that, which is like, making sure that the distribution of outcomes is fairly equitable within those populations too. I think that's. But I was going to ask you about. Thank you for reminding me about population health. Is that sort of like your? People have varying definitions of population health, but it seems like a through line is just that health equity piece of just making sure that the distribution of outcomes are kind of similar throughout different populations. But please, what is your kind of go-to definition?
Well, we look at a lot of this through the perspective of lifespan inequality, right? So if you wanted to take sort of the ultimate arbiter of disparities, right, it's when one community dies younger than another community, right? That's for whatever reason that might be. We have a life expectancy in this country that should be equal for everybody, but we find across the city of Detroit, there are pockets, most of the city actually, where people are dying anywhere from 5 to 15 years younger than the state average, which, is a little bit worse than the national average. And so we come at it to say from a population perspective, our goal is lifespan equality, right? And what we want to do is reach as many people as possible at a big level. And our population, so population health gets different definitions because it depends on the population you define. It can be by race, it can be by region, it can be by hospital, it can be by diagnosis. There's many ways to think of the population. We come at it from the population of our region, and we say our goal is to improve the health for all, and recognize that, again, it's an equity perspective, but it's an equity perspective that isn't solely directed towards the lowest end of the socioeconomic status, because that's important, obviously, critically important. But when we're really talking about improving health outcomes for all, it's everybody, right? It's everybody. And so our goal is to improve the population health of our region, which allows people to live longer, which creates more prosperity and opportunities for family members to be there as kids and grandkids get older. And, it adds vibrancy rather than allowing disease to sap vibrancy from the community.
I think that's a great note to end it on, Dr. Levy, because, we brought it back to community there at the end. And I really appreciate your time today. And if anyone wants to explore this topic further or maybe even reach out to you, what do you recommend? Just go to the Wayne State website, or is there a more specific website you recommend?
Well, people can just email me if they want. I'm very responsive, as you know, from our engagements.
That's right.
P. Levy, P-L-E-V-Y at med.wayne.edu. But you can also go to waynehealthcares.org, and there's information on the mobile program. But honestly, if you just search Phillip Levy and mobile health, a lot of information will also come up.
Well, thank you so much, Dr. Levy, and thank you and everyone. I can really corroborate that he's really good at quick responses. So do reach out if you have a question. Thank you so much for your time today, Dr. Levy, and we'll have you back real soon. Thanks so much.
Thanks, Chris. Look forward to it.